Dr. Flannery, welcome to the show.
Hey, Dr. Larry, thank you so much for having me on. I look forward to our discussion.
Yes, and so as it goes, formalities, we've got to get them out of the way first. Just give us your full name and then your license type and board certifications.
Yeah, so Walker Flannery, MD, board-certified orthopedic surgeon, fellow of the Academy of Orthopedic Surgery, and physician owner at OSMS.
Wonderful. And then as far as locations go, you practice out of which locations at OSMS?
So I'm in Green Bay and also in Marinette. Marinette every Friday.
Okay, and the local folks around here in the county know that Marinette is close. Green Bay is almost as close, and I know that they use both those facilities. So now this is just purely out of curiosity, out of my own brain here, but why did you choose your specific specialty?
So I chose general orthopedics because it really was what I found my skill set adapted to well. So in training, you get to see the hands-on nature of orthopedics, where you're really looking to fix something in the operating room, but you also get that nice mix of also talking with patients in the clinic and really seeing how they recover and come along. So I've really enjoyed all aspects of it. It's really that one specialty where you're using power tools. And growing up, fixing my dad's race cars and working in the woods with him with his logging business, it's just really a specialty unlike anything else.
You said, I'm sitting here smiling. You said power tools. One of the things, obviously, as a chiropractor, I'm talking bone joint stuff with people. And so people will come back from surgery, from orthopedic surgery, like, do you know they actually use carpentry tools, Dr. Larry? And I go, yeah. Did you ask them what type? So what type of, and they're into it. They're not even weirded out by it. They think it's the coolest thing ever. What type just of carpentry tools do you use? Do you have like a Makita or a DeWalt or what are we talking here as far as carpentry tools?
Yeah, so there's a few different common brands, but Striker Power is what we're mostly using, and you have a variety of saws and screwdrivers and mallets, but even a jackhammer that is a very controlled toned down version that we use in the operating room.
Well, I sent you guys a total hip last month, and he happened to be a retired carpenter by trade and hobby as well too. So he came back in. He's like, "Hey, Dr. Larry," he's like, "So he told me," he said he got in there and he had a bang, bang, bang that stem in there. So I got the full like theater of the mind, and he was so excited. He's happy with his new hip, by the way, too. So it was just kind of this great conversation. It just happened to have, and yeah, it's essentially carpentry work, and you're rebuilding stuff to make them better. And I always tell people too, as a side comment, and we're going to dive into the hip replacement here in a second, but I say I would much rather tell you need a hip replacement than a spine surgery. So I'm always, in a sense, happy to refer out for these hip replacements. Okay, so as far as types of conditions that you treat, what do you treat overall as far as what your sweet spots are? More about OSMS, what they can do for you, and how their, quote, procedure room makes your orthopedic care zoom. In just a moment, stay tuned. You're listening to the Dr. Larry Radio Show. We'll be right back.
Dr. Larry will be back in a moment. Break's over. Time to get cracking once again with Dr. Larry.
Welcome back. Or if you're just tuning in, it's right in the nick of time. I'm interviewing Dr. Walker Flannery, orthopedic surgeon and one of the owners of OSMS. And did you notice? He's just overall a super friendly doctor who scores high marks in patient satisfaction. This is part 2 of my interview for you. Roll the tape.
Yeah. So I treat common conditions, including hip, knee, and shoulder arthritis. Treat sports injuries, including meniscal tears of the knee, rotator cuff tears of the shoulder, any sort of fracture, really, and common hand conditions like carpal tunnel and trigger finger. Those are procedures that we even do in the procedure room in Marinette. So that would be something that could be done right in that office.
Okay, and while we're thinking about it, I had Dr. Scheckinger on last week. Those of you that heard that show, it was a great show just overall about OSMS. And I had on my notes to get to the procedure room. So I don't forget this week, because I told Darren I wouldn't. What is the procedure room? I know it's a little out of outline right now, but that way I guarantee I'm getting this in. Tell us what the procedure room actually is.
Yeah, so procedure room is an area that we have in our clinic that we can use sterile technique and have the equipment same as what we would in the operating room. And it allows us to do procedures that can be done under just local anesthetic. So we would talk about what we're going to do in the clinic space, and we would put numbing medication in there, the area that we're going to be working, give that 15 minutes to set up. We'd go back to the procedure room, set everything up sterile, still do a timeout, same as we would in the operating room, and we check to make sure that that area is numbed up nicely. And then we're able to do the procedure without any anesthesia otherwise. And so the patient is under a drape, but we're listening to some music. We can talk with them throughout the procedure, and they're able to go home without potentially even needing a driver. So it's a really nice way to keep those smaller procedures local.
Okay, so instead of, like I said, it fits a niche between having to go to the main OR and not just like a clinic exam room. So it's like a go-between room that you can get smaller procedures done, sterile and relatively quickly, and get people back out home quicker, I guess is kind of what I'm picking up on, correct?
Exactly.
Okay.
Yeah, and typically also for a less cost. You wouldn't have a hospital or a bigger fee with the facility.
I love that that you guys have mentioned that, and you're not afraid, ashamed. In fact, you even encourage to talk about that. Healthcare costs, as you know, have skyrocketed, and you guys, by being doctor-owned, patient-focused, have figured out how to deliver exceptional care, but for reduced costs. And those two don't seem to match each other, but you guys have figured it out, which is why you are one of the number one places I use for just overall orthopedic stuff. So I love that you will have no problems hesitating to bring that out. And that's your mindset and focus too, is you make these decisions how to get things done more efficiently for more reasonable costs. So I'm glad you brought that up again. Okay. As far as generally described, now this is more so patient education, patient sort of understanding. There's a little bit of a nebulous, hazy concept out there of when it's time to call an orthopedic surgeon. So first of all, does that always mean there's surgery? So I am sitting in my house, I've got some type of bone joint musculoskeletal issue. Not sure if she called Dr. Larry or not, but ultimately I'm like, I'm going to call the orthopedic on this one. When they call you, does that always mean it's going to be surgery?
No, absolutely not. Of course not. So, but I think that is a little bit deceiving when, orthopedic surgeon is our title. But surgery is generally a last resort. Most conditions, we're looking to manage them in non-operative ways. But ultimately, if it gets bad enough and those other options fail, then surgery may become the best tool, best answer that we have. But we see all types of musculoskeletal injuries and conditions. Basically, we specialize in evaluating and managing conditions of bone, joints, and muscles. So a lot of times, I think in a primary care office, physical exam can become less of a key element, with more labs and other tests being done. But really in the orthopedic world, a physical exam is still very important. And so evaluating stability of a joint and determining what treatment options there are is really our niche. And so I think that's where you'd want to seek us out with any of those conditions.
Yeah, and I had a patient a couple of weeks ago, and she was telling me that she had been to a primary care, and she asked, and it was a non-surgical situation, but it was musculoskeletal, but needed a little bit more of a kind of an expertise, like you said, exam. And she says, well, do you think I should call an orthopedic? And the response from the primary care was, oh, no, don't waste their time with that. It's not surgery. You don't need to see them. They don't want to see you. And I actually had to correct that statement. I said, that's from the ones that I've talked to and know, and the ones I don't know, but when I refer in, they're more than happy to evaluate a musculoskeletal condition, to give you an opinion, even if they have to, just kind of assess the joint, run, X-ray or even an ultrasound. And so you basically just kind of answer that question in a very similar format. So, you always seem to be happy to see a patient and just address whatever they have to, whatever their musculoskeletal need is, and then give them recommendations from there. I've never had at least the folks that I use, where like a sour visit. You're always just, happy to give advice and evaluate patients and cases. So, which ties me into the next set of questions here. What are some of the non-surgical reasons to see an orthopedic surgeon? Just give me your top three off the top.
Yeah, so I think joint pain in general, with commonly that being related to arthritis or wear and tear of the joint. Other common problems would be weakness or numbness to a particular area or extremity, with seeing a variety of things like carpal tunnel syndrome and other nerve compression. We can evaluate that. Treatment options. And then thirdly, I guess for an example would be any injuries. If you have a fall, a sports injury, I think we are the best to evaluate those cases. And really, in terms of those treatment options that we're talking about that are non-surgical, you're looking at things like low impact exercise, guided home exercise program, or physical therapy. There's different braces depending on the condition. For knee, for elbow, for wrist. There's a few different injection options that can be considered, which we review all those options and talk about those. Obviously, medications just on a basic level of a Tylenol or maybe an anti-inflammatory short term. Looking at weight loss and just evaluating someone's overall health. And then we would look to evaluate, those nerve type conditions, potentially with a nerve conduction study or guided therapy. There's just a whole array of options of things that we can do outside of just the surgical realm.
Wonderful. And then I talked about this last week, but I want to mention again, you guys do have an acute care clinic, and we mind taking about a minute to describe that acute care clinic, where it's at, and what that purpose is for.
Yeah, so our acute injury clinic is an access point that allows people to get in right away to see us. If something seems to be more urgent because we've had an acute flare of the pain or there was an injury, we want people to be able to get in and evaluated right away. And so it's just really an access point for that acute injury clinic to get people seen and make sure that things that are needing to be addressed in a more timely manner are being done so.
Okay. And what are the hours of that acute care clinic?
Yeah, so our clinic is 8 to 5. So those would be the hours that someone could come to the front desk, explain what they have going on. If it seems quite urgent, we'll escort the patient right back to a room and potentially get an X-ray and get things evaluated right there.
And that's Monday through Friday?
Monday through Friday, 8 to 5. Yep, exactly. Okay. And we definitely have times where people come right from urgent care or even the emergency room where they just say, go to OSMS, or that's going to be the best option for getting this taken care of.
Excellent. Okay. Well, thanks for highlighting that again. All right. Now I want to jump into the main focus of the show. And the fact is that as I led into the segment here today, was more focused on the hip and specifically the anterior hip replacement surgery. You obviously be an orthopedic surgeon, but also you dovetailed in this anterior hip replacement surgery. I started getting some static on that in a good way. People started talking about it a few years ago. Did you hear about anterior hip, Dr. Larry? I heard we got to travel to XYZ Nowhereville to get it, and out of state, far, far away. But you do focus, or it's one of your specialties, maybe, if I can say it, and you correct me if I'm wrong, as far as the anterior hip replacement. So let's draw in a little bit on that, because I'll tell you, talking to patients, what they come out of it is, do you know, with the anterior hip, it's a lot less downtime. You're up on your feet better, quicker. Did you know Susie Q from Somewhere? She got it done. She was doing great. So I want you, coming from you, to tell us about the anterior hip replacement, but we'll start off with a little background. Why anterior hip replacements, and why was it developed?
Yeah, anterior hip replacement, most common surgery that I do. We probably did about 200 of them last year, me personally, and it really has become a great surgery and a nice niche of my practice. And anterior approach was first utilized by trauma surgeons, actually. So if someone had a fracture of their pelvis or around the hip, they would use this approach to go down and fix the fracture. And it was about 20 years ago that Dr. Mata, who did trauma surgery as well as joint replacement, thought, this seems like a pretty good way that we may be able to do hip replacement. And it was really, the advantages related to that of being more minimally invasive on the approach to getting down to the hip that was so appealing. It was muscle sparing, which is really nice to not have to cut through the muscles, but instead just spread in between the muscles to do the hip replacement. And there took some advancements along the way, a development of a specialized table called the HANA table that would position the leg to allow that to be done that way. But really, then once that started, it's really just blossomed from there. And I think a big part of it is from patients hearing about it and seeing how well people are doing. And it's really been great. And that's also been borne out in the literature of having actual research studies showing that overall recovery is easier. Earlier on, people have better functional scores and less pain, less use of the pain medication. So studies are showing that people on average can get rid of the cane and walker 2 weeks sooner, and less likelihood of having a limp to their gait early on or even long term. And there's not some of the same precautions or restrictions after surgery in other approaches. There are certain ways to do hip replacement that may involve keeping weight off of the leg for 6 weeks, which is, quite the restriction. You also have what we call hip precautions for positioning. So with a posterior hip replacement, for example, recommendations are to not bend the hip past 90 degrees, to not cross the legs. So you have to worry about using a riser for the toilet seat even, or, getting into a low sports car. Those risks are the highest the first 3 months, but really the general precautions are considered lifelong. And so we don't have those precautions with anterior hip replacement.
Excellent. And so, just listen to you talk, and that's the nice part about it, versus me giving the advice, listening to the advice as well too, because that's what we're doing right now in this segment is we're giving the advice. So people who are listening and tuning in right now, who are possibly perhaps fitting a category of, we know the joint is making some noise, you're getting the hip pain, the buttocks pain, the groin pain, and maybe a little bit more of a limp. Maybe you notice the leg's a little shorter. As this one individual told me, he looked in the mirror and saw he was a little teeter-tottered and it needed a hip replacement. What is the special criteria for the anterior hip? Is there any special criteria? If it is, let us know what that is, or what your criteria is to evaluate and see. Excellent interview. Now, if you've heard about and are curious about the anterior hip replacement versus traditional posterior or lateral and want a great piece of education directly from the doctor who performs this procedure, then you're not going to want to miss this next segment coming up. Also, he walks us through the procedure, a bit of audio and theater of the mind. Seriously cool stuff, way better than reading on WebMD. Stay tuned. This is the Dr. Larry Radio Show. We'll be right back.
We'll be right back with Dr. Larry. We're back with Dr. Larry.
Welcome back from the break. So listen to how this doctor-owned, patient-focused, handpicks their doctors. Also, too, and this kind of a neat thing that they do at that clinic as well, too, at OSMS. Here's one of them, Dr. Walker Flannery. He's going to take us through the anterior hip replacement. And so roll it, Reed. We got another great little segment coming up for you.
Yeah, so for me, I do all my hip replacements anterior. So if someone is a candidate for hip replacement, then they're a candidate for that approach. So some studies show, higher risk patients would be someone over BMI 45. And that risk is higher regardless of the approach for hip replacement. So I don't do any change based on that. We look to optimize patients' health prior to surgery to reduce the risk of problems, with problems being things like infection or a fracture, with those risks being relatively low, less than 0.5%. But in higher risk patients due to their comorbidities or their weight, we may look to try to optimize them more before surgery to lower that risk. But there's not any criteria where I'd say, I need to do a different approach. I think for some surgeons, that is the case, though. So you may go to a certain surgeon, they may say, no, you're not quite meeting the criteria. And I think that just has to do with anterior hip replacement really requiring a specialized skill set that, traditionally was not part of training programs. So really just over the last 10 years, that has blossomed to be part of the training that we get. And so if a surgeon is trying to sort of pick up anterior approach or add it into their practice, they may look to just try to do the easiest case first and kind of build their confidence and their skill set. So they may pick the thinnest patient with maybe less arthritis or deformity to the hip, allowing for them to be successful with that, and then continue to grow their practice in that direction.
Okay, and you just answered a question that I did have in the back of my brain. There was you do this exclusively. You're not doing the posterior approach or the lateral. You stick exclusive to the anterior hip, correct?
I do, yeah. If someone, you have your initial surgeries for arthritis, and then certainly if someone had a complication down the road, they may need a revision surgery. If someone had a fracture or a part wore out or something happened, sometimes I'll see patients that may have had a posterior hip replacement previously, and so then there's a decision: do we do the revision anterior or do we go through their previous incision posterior? And I think there's risks and benefits to both, and we would discuss that at the visit. Partly it depends on what we're expecting that would be needed in the revision surgery, but really in terms of any primary surgeries for arthritis, I would go exclusively anterior, and I think that just really has to do with the advantages to it. We talked about the minimally invasiveness and the recovery, but what really isn't talked about that is sort of the biggest advantage and the most important reason that I do anterior hip replacement is lowering the risk of dislocation. So dislocation would mean that ball would pop out of the socket, the two sides of the hip replacement. If that happened, that's a really bad day. You can have to go to the emergency room and have your hip put back in. And if that happened multiple times, the surgeon may have to revise it and change the part position to improve that. And so that's why with other approaches, there's certain precautions. And with anterior, with not cutting through the muscles, we don't have those same precautions. People can move in any way that's comfortable. And research studies show that despite not following the precautions, the risk of dislocation after anterior hip replacement is less than 0.5%, as compared to 2 to 3% with other approaches. So that helps me sleep better at night, knowing that people have lower risk. When they talk to me about things they want to get back to, it also just makes me more confident that they're not going to have issues.
Yeah, exactly. And it boils down to the human component too. You're providing a service and a procedure. You're doing these types of operations on patients. You ultimately want them to maximize and be at the full function that you expect and they expect. And so if there is a reduction in risk, or like you said, dislocation, as it's had, and I've had patients that have let me know that that's happened sometimes 1 or 2 times on posterior hip, the anterior hip kind of essentially reduces that almost to close to a zero. We can't say zero, but a less than risk than a posterior or in other cases. Okay, so now as far as the procedure goes, I think this is, we can YouTube stuff nowadays, but coming from the physician that actually is performing the procedure, in a general sense, as far as a theater of the mind goes, I'd like you to briefly walk us through the surgery, the type of incision, the tools, and step us through a little bit of the procedure here as we're listening, so we get a kind of an understanding. And it helps from a couple perspectives. Information as far as that goes, coming from the source that provides and does the service and also does the procedure, helps put the mind at ease, and there's a comfort level as well too. It's one thing to kind of go out and seek your own source and maybe look at your own, but coming directly from the person that's doing it, just kind of walk us through the anterior hip replacement procedure. Just a little mini step-by-step here, just to kind of wrap our minds around it.
Yeah. So once we get in the operating room, patient typically has a spinal anesthesia. We make sure that everything is comfortable that way. We use the specialized table called a HANA table, where we actually put your feet in these padded boots, kind of look like roller blades or ski boots, and that's how we position the patient, kind of resting on their back, just flat, and making sure that they're comfortable before they even go to sleep. Arms are just resting at the side. We make sure everything is padded up well. We ask the patient, "Are you comfortable?" And if they're comfortable resting there on their back, then we drift them off to sleep. And we then have the hip marked and prepped out. And for planning our incision, we feel the front of the pelvis, and over the anterior part of the hip, I draw out a 4-inch incision. and it angles just kind of obliquely over the front of the hip, in line with where the muscles run, so that once we make an incision and we get down to that next layer, which is the fascia over the muscles, we're able to divide that in line with the skin incision and spread the two muscles that are underneath there, the TFL and the rectus muscle, and then right underneath that, already from the front of the hip, we can start to feel the hip joint. And once we know where we're positioned with the retractors around the hip joint capsule, so that's kind of what encases the hip, we split the capsule in that same direction and actually tag both ends of it. Those are nice markers that we can use throughout the case when we're positioning our equipment and retractors to make sure that we're in a safe position. And then at the end of the case, once we're all done, we actually repair that capsule back together as a nice barrier to the outside levels, in terms of lowering risk of infection and keeping that hip located. So that's an important layer that I think some surgeons, for visibility or for their comfort level, will actually remove the capsule. I think it's really important to keep. And then once we're down to the hip, we're actually going to remove the arthritic parts. So with the femur side, we can draw across the neck of the bone and then make a saw cut with that to remove the head and neck of the femur. And at that point, we're then able to look at the cup side or the acetabulum, and we remove the labrum and any bone spurs and any remaining cartilage, basically getting down to just a nice bed of bone. So anything that has nerve pain fibers on it, we've removed, so that we're really simplifying what the hip is. And once we have that, we can use reamers on the cup side. We've templated ahead of time, meaning that we've drawn on the x-rays and know what size we're expecting to get to. And then we actually ream up in increments until we feel like we're at the right size for that patient. And we can then put in a trial cup and make sure that fits in there nice and snug. And then we have them actually open the real one and put that in place. And if that's nice and secure, we're pretty much done on that side. If there's any question of the stability of that, you can put a screw into that cup to hold it even stronger. And then we put a polyethylene or plastic liner inside the cup, and that's the actual bearing surface on the cup side. And then opposite that is the ball that goes on the femur side, which is typically a ceramic material. And those are studied, millions and millions of cycles in the lab. We keep doing better and better of making those last longer to where now it's 0.1 millimeters or less per year that they wear down. So if it's over 5 millimeters thick, which it typically is, then we'd expect those materials to last over 50 years, which is pretty awesome at this point.
That is a fantastic piece of data right there. How long will my hip last? And you just nailed it. So in detail, as far as that goes, so you're talking on like you said, it's been studied millions of times over. So the wear on it is less than a millimeter per year, did you say?
0.1.
0.1.
Yep. So the new materials are, highly cross-linked polyethylene with vitamin E impregnated for antioxidants, and these parts I think are just getting better and better. We have actual data of them being in patients for 30, 40 years with good track record of 90% survival, and we think that the materials that we're putting in now, should do even better. So
if I'm a 51-year-old male and I've got an issue where it's obvious that failed conservative therapy and all the criteria is met, and no question I need a hip replacement. We're talking with what you just stated, it's going to last a solid 40 plus years, 50 plus years, based on the data so far, correct?
Yeah, I think that's really the case. I think early on, if you get the hip to heal in well to the bone and make sure things are doing well, the materials themselves really will last a long time.
Excellent. And you had mentioned, too, as I was listening to you walk us through this, separate the muscle. So far, all I heard was muscle fascia. No cutting of muscle or minimal cutting muscle. Is that correct, too? Or is there some muscles that you end up having to cut?
Yeah, absolutely. No, I mean, there really isn't. Rectus muscle is one of the quadricep muscles, one of the four, and that drapes over the front of the hip. I would say 9 times out of 10, we're able to just kind of work underneath that to divide the capsule and replace the hip. Occasionally, we may have to release one of the tendon heads to provide a better exposure, but quite rare, and that muscle is overall preserved.
Okay, and as far as from the moment the procedure starts till you're basically okay, I'm done. What is roughly the procedure time?
Yeah, procedure takes about an hour and a half.
Okay,
about 90 minutes.
90 minutes, and then as far as cases being successful cases, we're running out of time here for this show. I wanted to go over at least 3 cases, but if you could drill it down to maybe 1 or 2 cases out of the 200 you even did last year, where you're like, hey, run us through like 1 or 2 successful cases you've had with this type of procedure.
Yeah. So I had a gentleman come back this week now, 1 year out from having both of his hips replaced with us. We replaced them about 6 weeks apart. And he's an officer and works with the SWAT team. So it's pretty incredible. He's daily weightlifting, and he is jogging 2 to 3 miles, usually 3 times a week. So he's really active, and it's just awesome to see how he is essentially back to everything that he wants to do without really noticing his hips at all. So he's been a pretty neat success story.
And he's still working, you said?
Yeah, absolutely. So he's taking care of all of us. So
yeah, he didn't have to wait till his career was over with these banged up hips. So he basically got them done, and he's still out in the field doing his thing. Yeah. Okay, how about another case? Yeah,
so another is it could be multiple examples of this, but I had a patient that was told that she could not horseback ride after having hip replacement, and when she came to me, I thought, that's crazy. If that's your passion and what you love, there's no reason that you can't do that. So we've had replaced her hip, and sure enough, 2 months after surgery, she was back on a horse, and it's interesting. That's kind of a small world, I feel like, because since then I've had several other horse riding individuals that have came in and have had a similar success story. So.
Yeah. Well, it's between law enforcement and horse, and sometimes too, like you said, it'll come in waves. I remember a couple of years ago. It's a little bit off topic, side note, but I fixed up a really complicated vertigo case in the hospital. They're going to send her down to Milwaukee. And I figured it all out and got her better, elderly lady. Boom! Next thing you know, I'm getting vertigo cases in for like 2 months. And it's like, hey, I'm not a vertigo expert.
Found your niche.
Yeah, I'm not a vertigo expert. I just happen to, but and then a couple of them figuring out too. But sometimes things will come in waves. Okay, and as far as it goes, folks, you heard Dr. Flannery talk here. He is right at the Marinette office and also the Green Bay office. No need to travel 5-6 hours to get this procedure done. In fact, I was thinking before we came on the show today too that he did all of the types, but he's really just stuck to the anterior hip. In fact, he himself has done over 200 last year, and that's where his niche is and what he sticks to. So if you are that type of patient, if you're having this type of issue or any sort of orthopedic issue, folks, I really like you to consider using OSMS and the crew over there. And like Dr. Scheckinger said last week, is I trust anybody in my family here with any of the docs here. And so that's why it's nice to hear from a couple different ones as well too. But Dr. Flannery, if listeners want to contact you for an appointment, what is the phone number at OSMS?
Phone number is 920-430-8113. And people can also schedule online on our website, osmsgb.com.
And like a call I had this morning too, do I need a referral from primary care, chiropractor, anybody, or can people just call you guys directly without a referral?
Yeah, calling direct is absolutely fine.
Excellent. Okay, Dr. Flannery, thank you for coming on the show, walking us through the procedure, answering some questions. You were a kid that liked to play with certain types of instruments and stuff and logging, and it's all just worked out for your career. Here you are. We didn't get the chance to dive into that. We went into the clinical stuff, but ultimately, hopefully down the road, get you back on the show. We'll dive in a little bit more, some of the kid stuff you did, and then how that translates to you being a excellent orthopedic surgeon. Thanks again for coming on the show.
It'd be awesome. Yeah, thank you very much for having me.
You bet. Once again, here's OSMS's contact information again. On the web, osmsgb.com, and on the tele, 920-430-8113. And if you tune in for the whole time, listen to the interview, did a great job of walking us through the anterior hip replacement, and just hopefully, if you have any of those issues, they are the main clinic that I use and refer to. I think I've been using them for well over 7 or 8 years now directly, if I can, and haven't had one infection come back. And ultimately, the hip replacements and any rotator cuff stuff, they do just a fantastic job. And the patient feedback has been excellent as well, too. They just really have their processes and people down. Very efficient clinic as well, too. So it does make a difference.